Hey everyone, if you work in critical care, you already know that timing isn't just important, it's literally everything. Today, we're diving into an explainer on clinical mastery, the HACOR score for NIV success. We're going to unpack an absolutely vital ICU framework designed specifically to stop us from missing non-invasive ventilation failure. It's one of those essential tools that fundamentally shifts how we manage respiratory distress, taking us from reactive guessing to proactive, data-driven decisions.
So picture the scenario. You've probably faced it a dozen times, right? You have a patient on NIV. Maybe it's a 65-year-old with a severe COPD exacerbation. You've initiated therapy, you got the mask strapped on tight, pressures are dialed in perfectly. But as you stand at the foot of the bed, just listening to that monitor beep, you really need to know exactly how they're responding. Are they actually improving? Or, are they just burning through whatever physiological reserve they have left? Subtly deteriorating right in front of you while the machine kind of masks the decline.
And look, waiting too long to recognize clinical failure, that is the ultimate danger in the ICU. It is such a common psychological trap to just slap the mask on, see the oxygen saturation stabilize a bit, and assume the machine is doing all the heavy lifting. But here's the harsh reality. By the time it's blatantly obvious to the naked eye that a patient is failing, like when you're seeing profound accessory muscle use, paradoxical breathing, or frankly just gasping, you've already lost invaluable time. You're playing catch-up in a life-or-death situation. Because there is a direct, unforgiving correlation we've got to respect when making these calls. Delayed intubation directly equates to increased mortality. Why? Well, the longer a failing patient remains struggling against NIV, the more they just exhaust those respiratory muscles. They become hemodynamically unstable, their oxygen debt grows, and they're basically setting themselves up for a catastrophic peri-intubation crash. We absolutely cannot rely on gut feeling or just eyeballing the patient here. We need an objective, reliable tool.
Which brings us to Section 1, introducing the HACOR score and the 5 specific things we need to check. The HACOR score acts as your definitive bedside compass. It requires us to check 5 measurable parameters: heart rate, acidosis, consciousness, oxygenation, and respiratory rate. But it's absolutely crucial to understand this isn't just a simple pass or fail checklist. It's a weighted point system. Depending on how severely deranged each of these 5 vital signs is, the patient accumulates points. Basically, the sicker the patient, the higher the score. So let's look at exactly what drives this score up. Moving right into Section 2, decoding the 5 parameters, or breaking down HACOR. All right, the H stands for heart rate. This is the first critical vital sign you must evaluate. Think of it as a primary indicator of systemic stress. When a patient fails to ventilate properly and hypoxia or hypercapnia starts setting in, their sympathetic nervous system just goes into absolute overdrive to compensate. A persistent tachycardia, especially pushing above 120 beats per minute, is an early warning siren. You just cannot ignore it. And in the context of this tool, it adds significant points to the HACOR score. Next up is A for acidosis, pulling directly from your ABG. And we aren't just looking for mild shifts here. If the pH is dropping, say slipping below 7.25, and the acidosis is worsening despite the positive pressure from the NIV, it tells us definitively that the current pressure support is simply not clearing the metabolic or respiratory hurdle. The patient is losing the buffering battle. And naturally, the lower that pH falls, the higher the HACOR penalty becomes. Now, the C reminds us to strictly assess consciousness using the Glasgow Coma Scale, or GCS. In the absolute chaos of respiratory failure, it's so dangerously easy to get tunnel vision on the lungs and the ventilator screen, but a dropping GCS is a massive red flag. It often points straight to CO2 narcosis. A patient losing consciousness simply cannot protect their airway, clear secretions, or actively participate in the non-invasive respiratory work that's required. Even a slight dip in GCS ramps up the risk profile immensely. O represents oxygenation, zooming in specifically on the P/F ratio. That's the ratio of arterial oxygen partial pressure to fractional inspired oxygen. This is your hard, objective metric of true gas exchange efficiency at the alveolar level. It reveals exactly how much of that pure oxygen you're blasting into the mask is actually successfully crossing the membrane into the bloodstream. A plummeting P/F ratio means the intrapulmonary shunt is worsening, and let me tell you, it racks up HACR points incredibly fast. Finally, R is for respiratory rate. A sustained respiratory rate over 30 or 35 breaths per minute means the patient is still experiencing an immense, exhausting work of breathing. The entire physiological point of putting them on NIV in the first place is to offload those respiratory muscles and alleviate that work. If they are still severely tachypneic while on the machine, the therapy is failing to do its job, and the HACOR score will heavily reflect that immediate risk. Let's move to Section 3, the golden rules and scoring thresholds.
So when you tally up the points from those 5 parameters, the action plan becomes brilliantly black and white. A cumulative score greater than 5 indicates a high risk of NIV failure. That right there is your definitive warning to start getting your intubation meds, your team, and your airway equipment to the bedside. But if that score creeps greater than 8 to 10, you must intubate early. There is absolutely no room for, let's just watch them for another hour at that threshold. You take control of the airway immediately.
Which brings us to our final section, Section 4, Time is Life and the Evaluation Window.
You have the physiological parameters and you have the scoring thresholds, but when exactly do you calculate this score to make it effective? The entire protocol hinges on this single digit. Not 2 hours in, not at the end of your 12-hour shift when things look totally grim, just 1.
You absolutely must calculate the HACOR score at exactly 1 hour of NIV therapy. This precise, disciplined timing is what actually saves lives. 1 hour is the defining physiological window. It's long enough to see if the positive pressure is successfully recruiting collapsed alveoli and offloading fatigued muscles, but it's deliberately short enough that you can safely pivot to intubation before the patient enters an irreversible hemodynamic crash.
The core takeaway from this explainer is clear and entirely non-negotiable. Do not ignore these 5 signs. Casually waiting to see how things look in just a few more hours is a direct pipeline to the exact increased mortality we discussed earlier. You don't need to guess. The vital data is continuously scrolling right there on your monitor, and the objective values are sitting right in your lab results. You just have to look at it objectively and do the math.
Please burn this final medical mantra into your memory for the very next time you step foot into the ICU. HACOR high, tube early, save the patient. It perfectly and aggressively summarizes the entire philosophy of this clinical protocol. High scores unequivocally demand immediate, definitive airway control to prevent a tragic outcome. So, I'll leave you with this thought. When that critical 1 hour mark hits on your very next shift, will you remember to check the HACOR parameters, or will you let the crucial window of opportunity slip by? Equip yourself with this tool, trust the objective data over subjective hope, and never hesitate when the numbers tell you it's time to act.